to today's Grand Rounds. First, we'll have an announcement. Please join me in congratulating Andrew Drysdale in being selected as a William Webb Fellow through the Academy of Consultation Liaison Psychiatry. Andrew is one of our CL Fellows, and it's a terrific honor, and I can think of no better recipient. Congratulations, Andrew. Today's Grand Rounds is the second in a series of talks on structural racism, co-sponsored by the Department's Office of Equity, Diversity, and Inclusion. It also commemorates Hispanic Heritage Month. Please remember to also attend the Grand Rounds scheduled for December 1st by Helena Hansen of UCLA, which is also part of this series. Also, use the chat feature at any point during the presentation to submit your questions. We want to prioritize questions by trainees, so we're asking them to write trainee preceding their question in the chat so that we can prioritize them. It is my pleasure to introduce Dr. Joshua Breslau. I've known Josh since the early 1990s when he was getting his PhD in anthropology at Harvard. I remember he spent a summer with a few colleagues reading the collected works of Michel Foucault. He may have forgotten that, but I haven't. He then went on to get a second doctorate in epidemiology. I was very impressed. He then went on to get a second doctorate in epidemiology at the Harvard School of Public Health. Josh's work bridges the fields of epidemiology and mental health services research. He collaborated frequently with Ron Kessler and Ken Kendler earlier in his career. Ron was the mentor on his K01, working on the National Comorbidity Survey revision and other national data sets. He then developed expertise working with data sets on individuals of Mexican descent on both sides of the Mexico-US border in collaboration with staff at the National Institute of Psychiatry in Mexico. His work with Guillermo Borges on the impact of migration on the risk of mental health disorders among Mexicans has been especially useful, since it presents an unusual opportunity to compare individuals who migrate with relatives of migrants back in their country of origin. Josh is now senior health behavioral scientist at RAND. His recent work has included mental health services research focused on policy relevant topics, such as ethno-racial disparities in mental health service access, physical mental health integration, the role of stigma in mental health service use, and more recently, the mental health impact of COVID-19. He currently has grants from New York City and New York State, evaluating the accessibility and quality of several of our mental health services, such as our New York State Health and Recovery Plans and the Self-Directed Care Pilot Program. This last pilot study is being done with Anna Stefanschic's team at our Cultural Competence Center here at NISP. Josh publishes frequently with Harold Pincus and Molly Finnerty in our department. It is really a pleasure to welcome Josh Breslau to our departmental Grand Rounds as part of our Structural Racism and Hispanic Heritage Month activities. The title of his presentation is Mental Health Care Disparities and Hispanics in the United States, Culture, Epidemiology, and Policy. Josh.
Thank you very much, Roberto, for that very generous introduction. I'm going to go through the slideshow set up, and if I could maybe just confirm that you're seeing the title slide of the talk. Great, and that you can hear me. Thank you very much. So thank you, Roberto and Christian. This is really an incredible honor to be asked to present to Columbia Department of Psychiatry, which I consider in itself a great honor, and to be asked in honor of Hispanic Heritage Month is also additional honor. It really encouraged me to go back over a lot of the work that I've done over the last couple of decades and put things together, try to put things together in an interesting and useful way. As Roberto mentioned, really coming to the topic from a broad perspective, trying to go all the way from the kinds of things that we think about in anthropology to using epidemiologic methods and population level studies to try to understand those cultural processes, social processes, and then to pull out lessons from that for policy. And at the RAND Corporation, that's what we do. Policy is our focus, and that really being at RAND has always encouraged me to make that connection. The plan for the talk today is start with reviewing the research on psychiatric disorders and epidemiology of psychiatric disorders among Hispanics in the United States, work in that area, to link that in some way to disparities in mental health care. So starting with studies of disorders, and then we'll look at studies of mental health service use and how those two are related, and draw out implications for policy. Behind this, I just want to raise this key policy question that I think we'll return to at the end. But I think this is kind of the biggest overarching big picture policy question in this area. And it's really in some ways a challenging one, which is to what extent so do policies that increase or improve mental health care in general, that target the entire population, are those effective at addressing institutional disparities in our healthcare system with respect to Hispanics, with respect to mental health care in particular? But these same issues, of course, also come up with respect to other aspects of medicine and other underserved groups. So, and of course, these same questions come up in other areas of social policy. But I think that's the question that we'll want to be thinking about in the background and kind of return to once we've reviewed this, the research in this area. And so in talking about Hispanic mental health in the United States, there are two major themes of research corresponding to two major social processes that shape this field. The first, and we're going to spend a lot of time talking about both today. The first is kind of broadly what we can think of as the dynamics of migration. So, the Hispanic population in the United States has diverse origins in multiple countries and cultures. There are very complex social processes that shape the coming to the United States, the process of migration. There's selection within the countries of origin, return migration, continued connections with the country of origin, very different situations, for instance, between Mexican migration and migration between Puerto Rico and the mainland. And there is a long history in sociology of looking at this set of issues in terms of acculturation and enculturation in terms of, so how are people from other countries, from sending countries, incorporated into the culture and institutions of the receiving society? So there's a whole set of issues related to migration and that set of processes. There is another set of issues that, and the theme of this series, as Roberto was saying, of structural racism, really comes in here, which is related to ethnic stratification, which is that the United States is an ethnically stratified society. We have hierarchies with respect to race and ethnicity. These are not international issues. They have international implications and components, but they're largely domestic. social processes. These are not related to where people come from necessarily, but they have to do with how ethnic differences are created and reproduced over time, how they are institutionalized structurally within the United States. And this involves exclusion from social institutions, including, but of course not limited to, healthcare. I think that there are particular issues not only within healthcare, but within behavioral healthcare. And I think trying to focus on, try to understand what is specific about behavioral healthcare is important within the context of understanding these broader issues of institutionalized hierarchy and exclusion. So with those two major concepts in mind, I'm going to start with getting into the epidemiology of psychiatric disorders in relationship to migration. So really starting off with the first of those issues, the dynamics of migration. And we're going to go back to really the first study, psychiatric epidemiologic study, to look at the issue of immigration in the United States. And this is the Epidemiologic Catchment Area Survey, which is a landmark study in the early 1980s, paired at the time with the emergence of the DSM-3, the first really large-scale epidemiologic survey to use standard criteria for psychiatric disorders in a general population survey. For those of you interested in the history of psychiatric epidemiology, go look at the study. One of the sites of this study was in Los Angeles. And in Los Angeles, they were able to look at the Mexican-American population and to compare within the Mexican-American population, those people who had been born in the United States and those people who had immigrated. And really the first major finding was that immigrants had lower risk for psychiatric disorders, and this is kind of across the board, as you can see in this slide, than the US-born Mexican-American. Now, this finding at the time really ran counter to expectations, given the sense that it was really more, it would be more the immigrant population that would be exposed to much greater socioeconomic stresses, social stresses, family stresses associated with migration than the US-born, who were more settled, more and more supported by a local community. But it was a very, as you can see, very consistent finding across disorders. And as it turns out, a finding that in large part has stood the test of time and really been replicated over multiple studies, with some, as we'll see, some important caveats to that. So we'll go forward a little bit in time and start looking at this issue of what came to be called by some the nativity gap. That is the difference in risk between immigrant generation, people not born in the United States, and people born in the United States of the same race ethnicity. So could be the first generation to the second generation, or the second and higher generation of groups in the United States. And we found that, studies found that, and this is data from the National Epidemiologic Survey of Alcohol and Related Conditions, these findings actually are very consistent across large surveys. And what we found is that, so in this this graph we're looking at the relative odds of having a mood or anxiety disorder. So being right between comparing the immigrants with the US born. So being right at 1 means that there's no difference at all, that they're just the same. And what you see is for most groups, the odds ratios are below 1, which indicates lower risk among the immigrants relative to the US born. And you can see also we have this finding here for Mexicans, Mexican immigrants compared to US born Mexican Americans, and also across a number of other immigrant groups. I'm sorry you can't see the African Caribbean group, but that you see kind of where that's located. An important piece to this that emerged and also has been remarkably consistent across studies, and maybe this is an area I know Christian works quite a bit in, is that we did find a big difference between the two largest Hispanic subgroups, that is between Mexicans and Puerto Ricans, and that there really was no association between being an immigrant, or in this case, in case of Puerto Ricans, being born on the island of Puerto Rico versus being born in the United States in risk for psychiatric disorders. So an important and large difference, heterogeneity within the Hispanic population with respect to origin. I should also mention another important piece here is that when we look at the US born in each of these groups, and we compare them with the US born non-Hispanic whites, there is the risk for disorder is very similar. So in none of these groups are we actually seeing kind of higher rates compared to the general population of the United States. Really, the nativity gap is a story about differences between immigrants, and then by and large, a similar level of risk for disorders among the US population. There's more subtlety to that if we want to get into that in discussion, but that's a reasonable generalization. It's important also to note this upper part of this graph is empty. So there really aren't any groups where we see the opposite effect, right? So no, at least in to the extent that we can do this in these large studies in the United States, we don't find groups where immigrants have higher risk than US born, which is an important piece to note that in terms of what we have been able to look at so far. The next really interesting and I think important finding came from studies that looking into these the nativity gap in more detail with respect to the age at migration. It turns out that the age at which a person comes to the United States has very big implications for their lifetime's risk for mental disorder. And in fact, what we find is that this so-called the nativity gap or the immigrant advantage is really only exists for people who come to the United States as adults. And so, or another way of looking at it is that it's not where you're born, but it's where you spend your childhood. And if you spend your childhood in the United States, you're basically at about the same level of risk as people who are born in the United States. If you spent your childhood outside of the United States, so particularly in Mexico or in Cuba in this case, and to some extent, even in Central South America in these data, you have a significant advantage with respect to people who spent their childhood in the United States. This should note showing across Hispanic groups here, the same finding in relation to age at migration is also found among, we also see it in data on Asian Americans and among immigrants and US born of African origin. Very similar pattern in terms with respect to age at immigration really being a major determinant of whether one is in kind of a very low risk group or one is kind of basically at the same level as the US general population. So I want to talk a bit about this study that Roberto alluded to, that Roberto mentioned, collaboration with Guy Borges at the National Institute of Psychiatry in Mexico City. Migration, the studies that I've talked about, all are done in the were all done in the United States exclusively, and comparing immigrants with the US born. But migration involves, of course, at least 2 countries. And what we did was take advantage, really a fortuitous circumstance, where where surveys were conducted in the United States and in Mexico at the same time, roughly the same time, using the same instrument. And the survey in the United States had included a large Hispanic sample. And actually, the Spanish instrument they used had been translated for use in the Mexico survey. The exact same instrument was being used in the Spanish sample in the US survey. And so it gave us an opportunity to look at these transnational aspects of migration and their implications for mental health in a new and really interesting way. And I'm going to just tell one story from that study. There are a lot, I think, a lot of interesting stories to tell, but I'm going to focus on one that is related to the childhood issue. It's a story about conduct disorder. And conduct disorder is extremely interesting because it's a childhood onset disorder, and because it confers really non-specific risk for a whole range of psychiatric disorders in adulthood. And I think, and also because it has a very strong genetic component as well. And it allows us to kind of put into focus the social origins of the increase in psychiatric morbidity associated with migration in a very interesting way. So let me tell that story in a few slides. First, this is how we arrange this comparison. So remember, we have national samples, a national sample of the country, the entire country of Mexico, and we have a representative sample of Hispanics in the United States. Within that, we have a sample of people of Mexican origin who are living in the United States at the time the survey was conducted. And across that transnational population of Mexican origin, we can say, we define 4 groups. We can look at, on the one hand, so group 1, which are Mexicans living in non-migrant households. So those are the survey in Mexico asked people whether there was someone in their household who had migrated to the United States or not. So we know if somebody's living in a household in which there's no migrant. That's group 1, in a sense, kind of the least exposed to the United States, let's say, just for shorthand. Group 2 is people from Mexican migrant households who spent their childhood through age 15 in Mexico. So they were in Mexico at least up until age 15. And that includes both people who were interviewed in Mexico, but they were in a household that had a migrant, or they were interviewed in the United States, but they came to the United States after they were 15 years old. So this US population right there is corresponds to the group that we see in the United States surveys that had lower risk relative to the child immigrants and the US born, is that one X there in group 2. Group 3 is kind of the next step. This is people who were born in Mexico their parents were born in Mexico. They were raised in the United States before age 15. So either they were born in the United States to Mexican-born parents, or they were born in Mexico but moved to the United States before the age of 15. So that's the first generation and the 1.5 generation. And then group 4 is the Mexican-American children who have at least one parent who was born in the United States. So these 4 are comparison groups. And what do we see? So what we see is something that's pretty dramatic. And I have to say, when I first saw these results, I was shocked to see the level of increase. What we see, so the reference, the comparison group that we are looking at here is this group 2. So these are the people who were in Mexico as children in households of migrants. And what we see are a couple of things. First, these people who are in households of migrants actually have a higher risk for conduct disorder or conduct disorder symptoms than people in non-migrant households. So there's a selection effect. So people who migrate actually are different from people who don't migrate, and in this case, they're at somewhat higher risk. However, even despite that higher risk relative to non-migrants, people who are here as children in the United States have about more than 3 times higher odds of having either of these conduct disorder symptoms, outcomes, that is having either 3 or more symptoms or having meeting the criteria for conduct disorder. And the people who are Mexican origin in the United, who are born with at least one US born parent, have almost 10 times the risk of conduct disorder. And I should add, this is extremely high, relative odds. It is a large confidence interval, but really more importantly, there are no differences between this group, that is the highest group among Mexican Americans, and the non-Hispanic white population. So it's not the case that there's elevated, that the risk of conduct disorder, prevalence of conduct disorder is not elevated among the Mexican Americans relative to the non-Hispanic whites, but we do see this enormous increase from going from Mexico to the United States across generations. And as I mentioned, there is, with conduct disorder, there is a lot of, we know conduct disorder has a strong genetic component, and there is there was a literature in genetic epidemiology of conduct disorder that looks at different types of symptoms. And the findings in that literature are generally that the aggressive types of symptoms are much more strongly genetically determined than the other kinds of symptoms, which are rule-breaking, kind of normative or norm-breaking kinds of symptoms. So things like school truancy or stealing, as opposed to starting fights. And what we found when we looked at these different profiles of symptoms of conduct disorder, what we found is this increase in risk for conduct disorder is really entirely within these non-aggressive symptoms of conduct disorder. And then if we look at this subtype that is believed to be more strongly genetically determined, we see really no difference at all. Really, I think one of the most striking findings that in many ways, that really demonstrates the importance of so really clearly demonstrates the social impact, or that this increase in disorders really is about a difference in social context. Okay, I want to start to transition to talking a bit about service use. So we've kind of covered the psychiatric, the epidemiology disorders. That's interesting and important. What about the dynamics of migration and mental disorders and mental health services? Well, we also see an increase in mental health services related to migration. And here we have a similar kind of set of categories moving from Mexico to the United States. On here, this side, we have the prevalence of 12-month prevalence of any psychiatric disorder across these groups. And on the other side, we have the prevalence of any 12-month prevalence of mental health services. And we see similar increase on both sides. So interesting is that also with service use, we see a similar kind of bump up in the 1.5 generation migrants, as well as in the U.S. born. So we see kind of both things are going up in tandem: prevalence of disorder and the prevalence of service use. What is one piece that's really interesting that we found is if we look at unmet need, so looking specifically at the people who meet criteria for disorder, who do not get treatment. In terms of absolute percentage, there's actually a larger percentage of people, the third generation or higher migrants, who have unmet need than in the people in the groups in Mexico, despite these large differences in the prevalence of disorder. So we've been talking about what's happening with respect to disorders, and then with service use in relationship to generation and the migration dynamics, that side of it. And I want to start talking about the other piece, which is about ethnic stratification and the institutionalized differences in the United States, structural racism, however we want to talk about it, impact on disparities in mental health services. And I think, to me, the most important way to think about this is that these disparities are not isolated to particular groups. They're not isolated to specific types of groups, but the things at whatever aspect of the mental health care system, of use of mental health services that we look at in the United States, whatever we look at, we see pretty stark differences between Hispanics and non-Hispanic whites. So it's not isolated. This is a general phenomenon. It's an important thing to home. And we'll look specifically at access to care, utilization of care, perceived need for treatment, and quality of care. Across all of these, we're going to see pretty large differences. So let's start with access to care. And this is data going up to 2017. So coming up past the first several years of the Affordable Care Act, when we did see, and looking at rates of uninsurance across Hispanics, Blacks, and whites. Rates of, for all groups came down, of course, with the Affordable Care Act, but there remain significant differences, not just statistically significant, but meaningfully large differences of 15 or 20% with respect to uninsurance among Hispanics relative to whites. Utilization of mental health care. So what we're looking at is data from another national survey. This is the National Survey of Drug Use and Health. When we combined over several years, this happens to be from 2009 to 2014, but I can tell you things have not changed. And we'll actually look at some more recent data from the survey later on. And here we're comparing each of these groups: Hispanics, non-Hispanic Asians, non-Hispanic Blacks, other and non-Hispanic Native and Native Americans here, comparing with whites in terms of use of any mental health services. And again, like before, if these numbers were at 1, that would mean that the use was equal among groups. But these numbers are much lower. So the relative odds for Hispanics for using mental health services are 0.56. And this is after adjusting for mental health status, adjusting for demographics, adjusting for physical health status as well, and adjusting for insurance coverage. So we still have very large gaps in terms of use of mental health services. In this particular slide, we're looking at use of any kinds of services. These findings are pretty much the same, whether we look at outpatient care, if we look at medication, psychiatric medication use, where the exception actually is in use of inpatient care. So inpatient care, in some cases, actually is more common among Hispanics and also among non-Hispanic Blacks than in whites. But of course, use of inpatient care is an entirely different phenomenon. It's much lower prevalence, and of course indicates a much more acute and often undesirable outcome in and of itself. Perceived need for treatment. So by perceived need for treatment, what we mean is whether a person themselves thinks that they need they should get mental health care, right? And it's a very profound and challenging aspect of structural racism and its impact on mental health services. It's something we're not good at really working into our the way we think about healthcare, because there's a tendency to see that as, well, that's that person's preference, right? To attribute differences, even when they're systematic differences across groups, to being cultural differences. So Hispanics may be, culturally less interested in mental health care. It's hard to, often in discussions of disparities, people want to factor out preferences. So if somebody, somebody doesn't perceive a need, well, if they don't get treatment, well, that shouldn't count as being a bad outcome because that's what they want. That's obviously something I don't agree with. I think it's where the important way to see this is differences in perceived need as being outcomes, effects of institutionalized structural racism and structural inequality across groups. Sorry, getting sound. And that they are outcomes of the relationships between healthcare institutions and communities. And so let's, with that in mind, look at a little at this figure here, which looks at the prevalence of perceived need for mental health treatment across 5 groups. And this group at the top, line at the top is non-Hispanic whites, which we can, and it looks across at the prevalence across levels of mental illness. So on the x-axis here, we have a group with no mental illness, mild, moderate, and serious mental illness. And at every level, and then we have these 5 groups that I should point out that, make sure I get the colors right. This light orange line represents Hispanics who took this interview in English, which is kind of a proxy for people who were probably born in the United States or raised in the United States. And this bluish, light blue line are people who, Hispanics who took the interview in Spanish, who chose to take the interview in Spanish, which most likely are going to be immigrants or people who arrived in the United States at older ages. And at every level, including at the no mental illness level, there's a much higher perception of need for treatment among whites than other groups. For non-Hispanic Blacks and Hispanics, there are very similar rates, kind of that are significantly below that of non-Hispanic whites across this whole spectrum. It's even lower among Asian Americans, and as you can see, extremely low among people who chose to take the interview in Spanish. So addressing the differences in perception and need are conceptualizing them first is extremely important. I think we need a lot more research trying to understand these, and also I think are challenging to think about how to respond to policy laws. Let me just dive into that a little bit deeper. We're looking at here is kind of a simulation or a thought experiment using the survey data. And on the left-hand side, we see the actual data on perceived need, on use of mental health services. Sorry, this is on use of mental health services. And we have the non-Hispanic white group, the Hispanic group that answered in English, and the Hispanic group that answered in Spanish. And then on the right side, we have 2 kind of simulated populations where we tried to simulate what would happen if we change something. And we made different changes in the population. And the first piece is we said, well, okay, what if everybody who perceived need had the same likelihood of using services? So we kind of equalized on likelihood of using services among people who perceive need. And when we do that, we really see almost no change from the actual. This other thought experiment simulation, what we do is we say, well, what if everybody perceived need at the same level? What if we modified that perceived need, but kept the probability of treatment conditional on perceived need the same? And when you do that, what you see here, you can tell, is a dramatic change in use of services. I think an instructive and an important lesson in terms of thinking about where we get, a big piece of the challenge in terms of addressing the disparity. Okay. We've talked about access, talked about perceived need, utilization, quality of care. This slide is about quality of care, and it's from a study. So people who are already getting into care, what's the quality that they're getting? This is from a study of Medicare Advantage plans, where we had data on, the HEDIS measures for quality of behavioral health care. And we have 4 measures here: antidepressant medication management, alcohol drug treatment engagement, follow-up after hospitalization with mental illness, and avoidance of drug disease interactions related to dementia treatment. For all of these, Hispanics performance for Medicare Advantage plans is poorer for Hispanics than it is for whites. Not just that, but what we also found is that a lot of these differences, the differences between Hispanics and whites, occur within plans. So that is, people who are in the same plan get different levels of quality, whether they are Hispanic or non-Hispanic white. And that within plan difference is really important for, it turns out, for thinking about, well, how do we change things, and how do we approach it? How do we approach some systemic changes, and how do we incentivize improvements in quality of care without creating further disadvantages for groups that may be harder to treat? Another important way to, I'm just going to check the time here. I think we're good. Another important window onto disparities, and our question about universal versus targeted policy, is to look at past policies and their impacts on not just on utilization, but actually on equity across groups. And we've done that. I'm showing 2 studies here. The first we did was on the dependent care expansion under the Affordable Care Act. So if you remember, this was the part of the Affordable Care Act that required commercial insurers that cover mental health care, that required commercial insurers to allow dependents to stay on their parents' health insurance through age 26. It made that a national standard. What we found was that the law was effective in increasing utilization of mental health services among young adults, especially for those who actually have a mental illness, which was its primary goal, and young adults are a particularly undertreated group. However, the effect was bigger, the improvement was bigger among whites than among Hispanics, and actually the equity impact was to increase rather than decrease disparities between groups. We also looked at Medicaid expansion. So this is the requirement, as we know, selectively taken up by states to raise the income threshold for eligibility for Medicaid coverage. We found, again, there was an increase in, not a big one, but some increase in utilization of mental health services among low-income adults in the United States attributable to the policy. We found there was, in this case, an increase for there was an increase in use for Hispanics and for non-Hispanic whites. But there was no impact observed for non-Hispanic blacks. And importantly, what we had found was that the increase was really among the number of visits, number of mental health visits among people who used care, and not in the number of people, who used care. So we did not see more people getting care, just people who were getting care have, on average, a higher number of visits, which is, of course, an important and positive finding, although not something that is leading to addressing in large portion the underutilization of care. Okay, this is something that is kind of new, and I just wanted to show you it, kind of introduce some ideas and data that we're working on. So far we've been talking about variations related to migration, kind of migration dynamics piece, and we've been talking about the ethnic stratification, structural racism piece in the United States. But what about variations within the United States in terms of structural factors? So question that we start to turn to is, are there meaningful variations in structural racism, structural inequality across the United States that may have impacts on use of mental health care and on disparities in use of mental health care? And are there lessons that we can learn, perhaps from areas where disparities are smaller, to use in areas where disparities are larger, that can help us address these issues? And as I'm saying, we're just taking some steps in this direction, but I think what I want to show you is just to kind of whet your appetite and give you kind of a sense of what we might be looking at, and share with you also my lack of any understanding of what we're finding so far. Okay, so what we're looking at here is each state of the United States. For each state, we calculate, using data from the National Survey of Drug Use and Health, the difference in use of mental health services between Hispanics and non-Hispanic whites. So within a state difference, and then looking at how that varies across states. And as you can see, we had no idea what we were going to find. Whether it was all going to be the same, or were we going to find that everywhere you go, there's kind of a fixed difference between Hispanics and non-Hispanic whites, or is there variation? And I think what our finding is that there's really a wide variation, as you're seeing right here. So there's only one state, and it's out of 51, so including DC, where Hispanics are more likely than whites to use services, and that's Vermont, which is, as you can imagine, total population less than some neighborhoods in Manhattan, the variations from California, which has the largest, almost 12% absolute gap between Hispanics and whites, up to a fair number of states that have pretty small, what we might think of as pretty small levels of disparity, say below 2%. New York is right here in the middle, interestingly enough. I just wanted to highlight that piece. There is, if we look at the map and try to come up with an idea of, if you can explain to me why the map looks like that, I'd be very pleased. So darker areas indicate larger disparities, but there really is not a distinct regional pattern that jumps out. So I think we are launching this, trying to understand what is accounting for this level of variation. Looking at the state level, because states are, of course, major policy actors, right? So there's a lot of mental health policy that's decided at the state. So we want to understand at that level. But states are not really communities, really, in any sense. And in some ways, if we want to look at structural racism, we want to look at local structural factors and how they influence local disparities. We want to focus on metropolitan areas, I think. And that's what we're looking at in this slide, which is we're looking at the 34 United States cities or their core-based statistical areas. If you think about them as metropolitan areas, the 34 that have the largest Hispanic populations. And then again, like we did with states, look at the magnitude of the difference in use between Hispanics and whites. And then we're just looking at the variation. And what we're finding is that there's a lot of variation. So from the average and the median are very close to 8.59% difference between Hispanics and whites. When you look at cities, there's no metropolitan area in which Hispanics are more likely to use services than whites. The closest it gets is about a 2% difference. And then on this side in the graph, we're graphing the level of use among Hispanics along the x-axis and the level of use among whites on the y-axis. To see, one thing you might think is that this has to do with overall level of service use in an area. But we find that the correlation between the level of use among Hispanics and the level of use among whites is actually pretty low. It's 0.34. So there are really independent factors that account for use of services by Hispanics and by whites within local areas. And again, I wish I could tell you more about why that is. At this point, I just want to kind of put that in front of you to say, look, there's a lot here that we can learn and really hopefully produce some new pathways for addressing disparities at a local but structural level. And that's the direction that I think we want to be going. So I'm going to start concluding and talking about some of the policy implications of what I've been talking about. And I think, to me, I'm convinced that disparities won't be reduced without an explicit policy focus on Hispanics and on other underserved groups. That is, if it wasn't obvious already, that's the conclusion. The way I answer the question I posed at the beginning. Disparities are not going to go away, even as risk for psychiatric disorders themselves may converge with the same levels as non-Hispanic whites. I don't think there's any reason to think that levels of service use are going to converge on their own. There are entrenched differences in the relationships between Hispanic and non-white communities and the healthcare institutions that serve them. And I think that's really where we want to try to understand better. And Um, and I think, and you know, what we observe is that the due to underlying inequality with respect to various structural barriers, increasing care, access to care for all without attending to needs of particular groups can actually set us back with respect to equity that we care about. I'll talk more about the policy a bit. I want to first put in a plug for a report that me, and some colleagues of mine at RAND did earlier this year. If you're interested in some of the broad pictures of broad issues in mental health policy facing us today, I encourage you to take a look at it. I also think I will say one really optimistic thing. I think we are in a period now of historic opportunity for change in our mental health system, in terms of quality, in terms of access, and in on a lot of fronts. And I'm not going to go into detail. We really explain it here. We're in a period of enormous change and opportunity, and I think it's a great time to really get involved and inform yourself, and be a part of that change in the mental health system in the United States, which, you know, for many of us working in this area for a long time has felt like being in a slow train wreck. You know, now feels like we have some reason to expect some reasons for hope. Okay. Policy implications with respect to services, health services. And I think these are things that are largely well-known, frequently discussed. And for each of these, there's a large literature. And I'm just going to mention these here and not get into details in terms of workforce development that's focused on Hispanic population, and focused on treating other underserved groups. Cultural competence. Telehealth, the use of the importance of telehealth to improve not just access to services, but access to better matches between patients and clinicians, access to care that better meets the needs of patients in their lives. Primary care-based mental health services, and coordinated care model. These things are all extensively discussed in the literature, and encourage you to dive in. The one thing I would note is that you know, of course, we're coming out of COVID, the experience of telehealth, its future transformation of mental health services is just a huge question mark. I think, you know, there's an enormous amount of positivity about the potential of telehealth to remain a core component of mental health services, to transform those services, to make services more available in a lot of ways. That really all remains theoretical at this point. You know, what we're hearing more immediately is about coming out of, hopefully, the pandemic is really an intensification of workforce shortages, difficulty hiring, that also increases in need, and that are also affecting underserved and low-income populations more severely. I want to talk a little bit more about the potential for systemic changes and how policy changes, systemic changes that are happening. This is not things that we need to start, but things that are happening can, I believe, really take, if they take account of the need to address disparities, can potentially have large-scale impacts. With respect to financing of healthcare and behavioral healthcare, move to value-based payment, which is in general a move to tie reimbursement for services to quality or outcomes of care rather than to volume, really offers an opportunity to incentivize increasing access to care, targeting underserved populations, tying measurement to population health, to social determinants of health, and incentivizing healthcare systems to really change the way, change their relationships with underserved communities. That's very positive, optimistic thing to say. I do think it's true. There also has a potential to do the opposite, which is to incentivize, by incentivizing quality of care. This is why I mentioned the issue of disparities in quality within Medicare Advantage plans. This is an example of how, if say those Medicare Advantage plans were incentivized to meet quality benchmarks, they would then have a financial incentive to avoid treating patients who they were likely to provide poor care to. So to avoid patients who are Hispanic in particular, which is obviously an adverse outcome. We do not want to have it. There are ways to do that. There are ways to structure the systems that do not create those incentives. One thing they do depend on, however, is having good data, both data on race, ethnicity, on identity of patients, and on quality of care, I should say, which, you know, having probably better data than better measures than and a better set of measures than we currently have. And the other major issue, I think, is related to mental health parity enforcement. So mental health parity is now the law of the land, but its interpretation and application is still very much up in the air, in particular around what are called non-quantitative treatment limits, about ways that insurers have to, quote unquote, subtly impact utilization by means other than explicit limitations on care, but provides a platform and a like an agenda and a really an unusually bipartisan support for requirements for such as network adequacy or methods of risk adjustment that take account of race, ethnicity, that do have the potential to really change the incentives for healthcare systems. And this is my last slide. I am putting up here, Roberto mentioned a project we're doing for New York City, and this ties in with the idea that disparities are local. This is a map of the city's zip codes, and I don't want to get into the details here, but just to give you the idea of what New York City is interested in, which is in mapping out against the population, the locations and capacities of the mental health system. And here we're looking at the numbers of mental health facilities in each zip code, and the number of facilities that claim that they provide services in Spanish. And then the orange outlined zip codes there are zip codes that are in the top quartile of zip codes in terms of the proportion of Spanish speakers. So I think there are ways for here in New York City, other cities as well, to get into their local conditions, local circumstances, use data in a smart way, and build systems that are more answerable to the communities that they serve. Thank you very much.
Thank you so much, Dr. Breslau, for this excellent talk. I really cannot imagine a better way to honor the Spanish Heritage Month that we are inaugurating, and also our structural racism series. So very grateful for you being here. What we decided to do is I'm going to make some initial comments, and then Dr. Luis Fernandez will make some initial comments. We're going to try to keep it brief because we have lots of really interesting questions in the chat so that we can also get to the chat. But that's how we're going to do this. So the first thing I really want to say is the depth and the breadth of your talk and the clear policy implications that you delineated are, in my opinion, exactly what we need right now so that we can really make the moment that we have right now, which I agree with you, is a moment of opportunity to meaningfully change those disparities, but so that they can come to fruition, so that we can really understand the processes at the level that they need to be understood so that we have a chance of changing them. So again, just thank you so much for this. And with that spirit, as a researcher that has also spent her career thinking about Latinx populations, one issue that has I have been thinking about a lot in our group, we have been thinking a lot about recently, is how much we have been missing in our capacity to fully understand mental health and also service utilization, mental health service utilization among Latinx groups by the way that we have ignored, mostly with few exceptions, the notion of race. Which I think there are very good reasons why we have done that. The concept is flawed in itself, and when applied to Latinx populations, there are even larger levels of complexities that are added. However, if we think, are we losing the influence or the impact, for example, of skin color in access to care and determination of access to care and some other service relevant processes that we are all interested in. It's even more interesting if we think about the acculturation issues and activity related issues that you brought in, because some of those are actually very much related to how the identification of Latinos with US census-based classification of race occur, right? So for a person to identify as Latinx, Latino, Latina, Latin, at this point, that implies a certain buy-in to the American culture, and how much our results are not also being determined by that at some point. And I think the plot thickens with the last census, the 2020 census, in which what happened, and these are preliminary results, but I've been reading about that still in the newspapers and et cetera. But with the changes that were made to the question about race, in which people, white and Blacks, are now asked to identify what their origins are. And the options of origins given under white are, I have it here for us to think about, but do not include any origin. Is German, Irish, English, Italian, Lebanese, Egyptian, etc. So what we're seeing now in the census is that, the identification of among Latinos, particularly Latinx, particularly with white race, has gone down by 50%. In Puerto Rico, the initial numbers that we had, it went from 76% to 17%. So the complexity is just building. So just for us to think about what implications that may be having in the way that we think about those processes, and is it the next challenge that we as a field should be tackling. So I will I said I would keep it brief. I am. I think Roberto could go now, and then maybe you could address our comments as a whole after him, and then we will open and go through the chat. Thank you.
Thank you, Cristiani, and thank you, Josh, for such a great talk. You've outlined, I'll try to be brief too, to give time for questions. You've outlined some of the main unsolved research questions about prevalence and about service use among US Latinx, and that reveals just how much work still needs to be done to understand the causes of these patterns that you've outlined. For example, how exactly does intersectionality of these characteristics, migration, nativity, acculturation, as well as Latino subgroup, class, Cristiani mentioned race, gender, and so on, how do these affect the prevalence of psychiatric disorder? There are hints in the data, I mean, exactly the mechanisms for this. There are hints in the data for how this could happen that we could look at. For example, the fact that you mentioned, and I'm glad you did, about the intra-Latinx differences in this pattern of higher disorder among people with higher acculturation, the differences between Mexicans, for example, where it features prominently, and Puerto Ricans, where it doesn't. And also there's differences across disorders that I won't get into, with the most significant one being in substance use, even more, consistently, more seen more consistently than others. So that's one big why question, or how, what are the mechanisms? Another big why question involves service use. How come we never, it is not possible for service use in the US among Latinx to increase to level of need, or even the level that is seen among non-Latinx whites? And you meant, which factors are primary and must be addressed first, which are secondary. Obviously, access to care and quality of care is essential, but you've also mentioned perceived need for service use as being an important factor. And we still, that begs the question, what are the factors that lead to this difference in perceived need that persists even when you have diagnosable disorder? And how can we distinguish genuine preferences, which may come from all sorts of ideas about mental illness and how do you solve it and deal with it and manage and so on, versus bad experiences in the past due to structural racism and other forces that lead to people not accessing care, not being able to access care. And the third why is, why these disparities? You mentioned it, and it's your beginning work in this area, and it's a very important work, I think. Why such difference in access to care, use of care across US cities and states? What kind of factors, including healthcare policies and programs, are important? I find that particularly important because we may find modifiable factor strategies, programs that are associated with reduced service use disparities that we could emphasize and disseminate. These decomposition or simulation analyses that you mentioned, one of there for perceived need, are especially important because they can provide causal information. If you manipulate the variables, you can see the effect. It's another way of testing quasi-causal inferences about potential important risk factors. So finally, one last minute I will take to say that it's very important to get policy right, as you've said. And I think it's also very important to understand why Latinx immigrants worsen over time and why the US born have higher risk. So we can target preventive measures. Prevention is always something we have a hard time getting to, but it's super important as well, as I'm sure you agree. And I just wanted to mention 4 possible causes that are under investigation. I'll just mention them as possible reasons for these prevalence variations associated with acculturation and nativity in groups like Mexican Americans in whom this pattern is observed. These are, first, the enculturation of immigrants and US-born Latinx as minoritized, low-status members of the US society, characterized by ethno-racial discrimination, limited opportunities and resources, and higher exposure to adverse circumstances, which leads to a whole set of negative consequences, possibly culminating in disorder. Second is the loss of protective cultural factors by the person and the family, such as due to the process of migration and of acculturation differentially across generations, affecting family cohesion. That's one big element, spiritual practices to cope with adversity and so on. Third is this loss of the ability to compare adverse post-migration circumstances with even worse pre-migration circumstances, meaning people sort of lose over time, or the new generation doesn't have this relative comparison that things may be bad now, but they were much worse later, which leads to sort of hope for the future. This is called relative deprivation. And fourth, the rising demoralization due to the inability to achieve expected socioeconomic goals over time or across generations. That's been called the frustrated status hypothesis. These are just some, as you know, and I guess your comments on this would be great, but I'm sure there are many other questions that also are super important. These causes all highlight the role that social determinants of mental health play in precipitating psychiatric disorders among minoritized ethno-racial groups in the US, and point to areas for intervention, including at policy and socio-political levels. And I want to end by thanking you, Josh, for all the work you've been doing over all these years. You've made a substantial contribution to our understanding of Latinx mental health, and we look forward to your ongoing work. Thanks.
Thank you, Roberto, for that. That actually means a lot. I appreciate you saying that. Let me just respond to a couple of pieces of that. I'm not going to, not everything, and then we'll get to the other questions. On the perception of need piece, the one thing I want to say to avoid misunderstanding on this point is that I don't think the question is changing people's perceptions. I think that the question is changing how, from the provider side to meet the needs. I don't want to set up the idea that, oh, well, we need to go out and change people's perceptions. I don't think that's, I think there has to be changing what we're doing to make it to become relevant to people who are not relevant. That's on us. And then on the classification and the intersectionality issues, that I totally agree, Christian. It's really, I wasn't tracking all of that. And it was only in 1980 that Hispanic became a category in the US Census. And then if you go back further in the census, there's a whole rich history of ethnic and racial classifications there that have changed over time. And it's really kind of a fascinating story. From what you're saying, and I think the way we separated race and ethnicity in the census and in a lot of surveys was really a pragmatic way to go about trying to separate Blacks and Hispanics and whites. We couldn't do it in one question, although we're really thinking about it as ethnicity. Mm-hmm. I think whether it's Black or white or Hispanic, we're really thinking about it as ethnicity race is kind of a cultural formulation of ethnicity. And so understanding how that's going to be, maybe even make it more difficult to look at some of the issues where we want to be able to, we're epidemiologists, we want to look at, the biology at some level. We also are, social scientists, and we want to know how people define things, because that's how we organize ourselves and what's meaningful to us. And we have to have both sides of that in order to do this work. So totally agree that, that's a really critical piece to be looking at.
Great. So I will prioritize the questions by trainees. So the first one says that the survey asks if the survey was, I think the surveys that you were presenting were conducted in high-risk communities, or did economic class play a role in how the data was collected?
These are all nationally representative samples. So within basic limitations of trying to get a nationally representative sample. They are not selected from a particular group, and they exclude, say, people who are institutionalized or homeless, but are generally representative of the full spectrum otherwise of the population.
Another interesting one, work by Groger and Trejo has looked at how Hispanic self-identification can vary in second and third generation Mexican Americans in the basis of socioeconomic status, i.e. families that experience greater intergenerational income growth seems to identify as Hispanic at lower rates in the second and third generations. I wonder how sample selection in these surveys account for the differentials in looking at the nativity gap.
Yes, I don't think so it's an incredibly important point and really fascinating and interesting when we start this whole idea of assimilation and acculturation kind of actually breaks down pretty quickly with intermarriage and with identification, and in many ways can impact how we think about these migration processes. We tend to kind of take these very first generation, second generation differences and then kind of extrapolate from that. But that's wrong. And partly for exactly these reasons. That said, I don't think that the differences really here are large enough to change that pattern, and I think partly that's because if we look at that where this starts becoming an issue, second, third plus generation, we're looking at 10th generation Hispanic Americans in Texas, versus second generation in Los Angeles. Those levels of they're very small differences, if any, among those groups that we're able to see, or between those groups and the general population. So I don't think that. So I think it's an incredibly important issue in understanding this, all of these pieces, but I don't think it changes that basic finding.
There's a comment about the mental health use existing within two separate payment systems and how much you think that the disparities could be related to the payer mix.
That's a good question. We don't really, we know about disparities in Medicaid specifically. I think we know that there are disparities, say, in among people who are insured commercially. We probably don't know a lot about different kinds of insurance. I think there's some evidence, and this is, I think, very important, that disparities are smaller in the Veterans Administration health system, which is a lot of, not only is it a different kind of system, a very integrated system, but also has a very particular selected population of patients, but clearly is different in terms of disparities. Difference in the military as well, actually in the military treatment system has much smaller, in some cases, no disparities in behavioral health use within the military. Again, a very different system, very self-selected or highly selected subpopulation. But important to think about in terms of the whole picture.
Another question that I think may be a good one for us to close. We have 1 minute about the main reasons that are driving the nativity effect and the main biases or stigma, disclosure bias or stigma that may be explaining the nativity effect. So that may be a way of putting it all together.
Yeah, no, that's great. There are large international differences in prevalence of psychiatric disorders. That is that when we use the same instrument and go and assess prevalence of psychiatric disorders to the best that we can, and we could talk a lot about limitations, but we do find really large differences. And I think, when you look at, particularly in our, look at, for instance, our study where we have Mexico and the United States, and we see these changes occurring in a very patterned way, that to me strengthens the my belief that we're seeing something that is about the symptoms and the prevalence of the disorders themselves, the way that we're defining them. There very clearly are, differences in how disorders are conceptualized, treated. What is the whole field of mental illness? We know we don't have to look across countries. We only have to look within our own country over time, and how our ways of thinking and classifying mental disorders have changed, to see that these are deeply culturally and historically shaped outcomes, and there's really no way around that.
I think this is a really nice closing. We're on time now. Thank you so much again for being here with us, and thanks everybody. Amazing questions, and hopefully we'll keep the conversation going. Thanks everybody.
Thank you so much. Take care.